natural history of disease means the how a disease process evolves over time without any intervention. I am not doing any diagnosis at an early stage, I am not giving any advice, I am not doing any type of intervention. I am just taking few cases, starting from its subclinical stage up to the stage of either recovery or death or development of some chronic manifestation with some complications. So I am not doing any type of intervention. So this is the natural history of the disease. That means how a disease process evolves over time without any intervention. So if we know the natural history of the disease, we can decide how the disease process can be halted by means of various intervention. It may be primary intervention, that is that is by giving some health advice or by means of vaccination, or disease process can be shortened by means of early diagnosis and complete treatment. And even in the late stage, we can reduce or minimize the further complications by means of rehabilitation. So one is primary intervention, that is by health education or by vaccination, or by secondary prevention by early diagnosis and treatment, and third prevention, that means disability limitation and rehabilitation. I think all of you know all these things because it has been covered in the second year or in the first year. So today I will discuss about the screening. So why screening is done and to whom screening is to be done and what is the advantage of screening. So let us discuss one by one. What is screening? Screening is the search for unrecognized disease. Search for unrecognized disease by means of rapidly applied test or by means of examinations or procedures among apparently healthy individuals. So what is screening? It is the search for unrecognized disease or any defect. Search for any unrecognized disease or defect by means of rapidly applied tests, examinations, other procedures to an apparently healthy individual. ঠিক যে কোনো টেক্সট বই দেখবে পার্কে এই দুটো তিনটে লাইন লেখা আছে। তাহলে one thing is search for unrecognized disease or defect. Another is by means of rapidly applied tests, examinations or procedures. A third, kader apparently healthy individual. Apparently healthy individual means, suppose I am suffering from diabetes, I don't know my high blood sugar level, but I am apparently healthy. So, until or unless my blood sugar examination is done, I will not be able to say whether I am suffering from diabetes. So, I have to do some tests. So, if the tests are done at an early stage, disease can be diagnosed at an earlier stage, and accordingly, if I took medicine, if I take medicine regularly, complications of diabetes can be prevented to a great extent. But until and unless I come to a doctor will not advise for any blood sugar examination, because diabetic patients usually have no signs and symptoms for years and years. When symptoms develop, it is too late. So, screening has a great role for detection of unrecognized diabetic patients in the society. So, what is the difference between screening and diagnostic test? Screening means it is done among apparently healthy person. But in case of diagnosis, we do examination to a patient who has come to you with some complaint. But in case of screening, patient is not coming to you for screening. Patient will not say that, sir, you do my blood test whether I am suffering from diabetes or whether I am suffering from hypertension. He will not come to you. He will come then and then only when he will develop some signs and symptoms. Clear? So, screening is done among apparently healthy individuals. The test or the procedure is usually done which is less costly and which is easier, which is acceptable. Which is acceptable, which is less costly, and which gives results earlier. So, the test to be applied for screening must be evaluated before undertaking any survey for screening program. Suppose if we do the blood test, if the blood test results are erroneous, if it is not properly evaluated, then it is useless to apply that type of test. Clear? So, one is among apparently healthy persons it is done. Another is the test to be applied must be acceptable, it must be less costly, and screening is done among the groups of people, not among the individuals. Suppose pregnant mothers are coming at your hospital for antenatal checkup, but we can do screening for VDRL test to detect undiagnosed syphilis among pregnant women. Because we know that if a mother suffers from syphilis during pregnancy, there is chance of congenital syphilis among the newborn babies. Clear? So, mother is coming for antenatal checkup, but we are motivating mothers for doing VDRL test. Also, we can motivate mothers for HIV test. Until and unless you do HIV test, you can't say whether he is suffering from HIV or not. Initially, there will be no manifestation of HIV infection. Say after 5 or 10 years later, patient will develop various signs and symptoms. But initially, there will be no signs and symptoms. So we can do viral test or we can do HIV test among the pregnant women. Even we can do hepatitis B surface antigen estimation. Hepatitis B surface antigen estimation among pregnant women to exclude the hepatitis B infection among the pregnant women. So, for doing screening, one is test should be rapidly done and it will be less costly. It is done among the groups. This screening is done mainly, initiative is mainly on the part of the doctors or the investigator. Here, physician is not taking any initiative. Here the investigator, they are taking initiative that we want to do some screening test to detect unrecognized disease in the community. Clear? And screening result is final and arbitrary. But in case of diagnosis, result may be modified based on further lab result or based on further examination. So, diagnosis may be modified based on clinical findings and also other lab results. But in case of screening, the screening result is arbitrary and it is final. And screening is not a basis for treatment. Screening is not a basis for treatment. But in case of diagnosis, once patient is diagnosed as suffering from tuberculosis, yes, patient is advised to take 80 drugs at least for 6 months or 9 months according to category. So, for screening, it is not the basis for treatment. Clear? And it is based on some cut-off point. Whether we will say, suppose in case of diabetes, whether cut-off level of blood sugar will be 200 or 180 milligram %. So, it is based on some cut-off point. Clear? So, these are the important differentiating point between diagnosis and screening. Clear? Next is, what are the types of screening? What are the types of screening? One is mass screening. You know that tuberculosis can affect not only the adults but also the newborn, also the geriatric group of people. So, we can do mass screening to detect undiagnosed TB patients in the society. Why? One sputum positive pulmonary tuberculosis patient can infect another 10 to 15 healthy persons, healthy susceptible persons. So, our motive will be to detect pulmonary tuberculosis cases in the community as early as possible. So, if we can detect the pulmonary cases at an early stage, we may prevent transmission of the disease among his close neighbors or the close roommates, and also he can be treated at an early stage, so he will be cured completely. There will be no further complications. If the treatment is delayed, patient may recover, but there may be some complications. So one is patient benefit, another is benefit in the society, because if 80 drugs are started within 3 weeks, patient will be non-infectious to others. Clear? So it is the mass screening. But for mass screening, one important disadvantage is that cost. If we do particular some test to diagnose TB, the cost will be more. But if we can restrict the screening among the high-risk group, our cost will be reduced to a great extent. High-risk group of people like pregnant women, like geriatric group of people. So if we can select all the workers who are working in the factories, laborers who are working in the factories, or the gangmen who are working in the railway tracks, they are more vulnerable. So if we can do screening among the selected high-risk groups, our cost will be reduced to a great extent. So this is selective screening. One is mass screening, another is selective screening. Third one is multiphasic screening. Multiphasic screening. At the same time, we are doing many screening tests. We are doing many screening tests. It has got some limitation. One limitation is that cost is more, and another limitation is that it has been found that there is no such gross reduction in terms of mortality and morbidity. Mortality, morbidity reduction খুব বেশি ডিফারেন্স হয় না। সুতরাং multiphasic screening, it has been criticized because it is too much costly. So these are the important types of screening. What are the uses of screening? What are the uses of screening? One is, একটু আগে বললাম তো ডেফিনিশনে, কি বললাম? Search for unrecognized disease. One is identification of the diseased persons. Identification of diseased persons. Example যেমন বললাম, among antenatal mothers, we are doing triple serology test. One is test for VDRL, another is test for HIV, another is test for HB infection. So, by doing these 3 screening tests, we can detect many patients who are suffering from syphilis or from HIV or from hepatitis B infection at an early stage, and we can intervene. So, there will be less or minimal chance of transmission of these diseases from mother to child. Another is, mother will be treated at an early stage, so mother will be recovered fully without giving rise to any complications. Clear? So, these are the important uses of serology. One is diagnosis of undiagnosed cases. Next is COVID-19 infection during COVID-19 pandemic. In the airport or the seaport, all suspected COVID-19 cases were kept separated. That is quarantine. They were quarantined for the highest incubation period. They are quarantined for 5 or 7 days, which is the longest incubation period. Why? Because to prevent transmission of disease to others. To prevent transmission of disease to others. Clear? The one is diagnosis, another is prevent transmission of disease in the society. Next is for educational purpose. For educational purpose, suppose a patient was, say, blood sugar level 180 or 190 like that, 190 milligram percent. Patient was informed that you must do the blood test after 1 month. If the blood sugar level, what is the cutoff level for diabetes type 2? PP sugar, what is the cutoff level? 200 milligram percent. So when the blood sugar level is 200 milligram or more than that, patient is diagnosed as suffering from type 2 diabetes. But those who are less than 200 but above 140 milligram percent, they are potential for diabetes. They will develop diabetes after 2 years or after 3 years. So, if we can detect these potential diabetic patients at an early stage, we can modify their diet, we can give them advice that you do regular at least half an hour exercise, you avoid high glycemic index diet. So, in this way, we can prevent development of diabetes for many years. Clear? Just by lifestyle modification. Lifestyle modification. So, with this type of intervention, we can prevent progression of the disease to overt diabetic one. Clear? So, it is for educational purpose. Another use for research purpose. We don't know, for many cancer cases, we don't know the actual natural history of the disease for many cancers. So, if we can do screening and if we collect the important data and if we do research in the long run, we can have some important input or it can give some important clue regarding progression of the cancer. For many cancers, we don't know when the cancer starts and how the cancer evolves over time and what are the types of complications that will develop for particular this type of cancer. We don't know in many cases. That's why for research purpose, screening is also important. So one is uses of screening. Next is what is the difference between screening and diagnosis. And third one is criteria for screening. It is very important. Every alternate year will get questions, what are the criteria for screening? Criteria for screening, we have to think two things. One is about the disease and another is about the test to be applied. For disease, when screening should be adopted, first of all, the disease for which we want to do a screening must be an important public health problem. Must be an important public health problem. Nowadays, among non-communicable diseases, diabetes and hypertension, these two are important public health problem. Almost every alternate house তুমি diabetic বা hypertensive patient পাবেই এবং above 40 or above 50 years age group, every alternate house এখন তুমি diabetic এবং hypertensive patient পাবে। সুতরাং screening is adopted for those cases which are an important public health problem. Clear? Next one is, we have some knowledge regarding disease progression starting from subclinical stage up to the development of signs and symptoms. For many diseases, we do not know the subclinical stage and the time of development of signs and symptoms. But for many diseases, we have got some knowledge regarding pre-symptomatic stage and the stage of development of signs and symptoms. So, there must be a sufficient time lag between subclinical stage and development of signs and symptoms. If there is no or the minimal gap between subclinical stage and development of signs and symptoms, screening test is not applied. Screening test is not applied. Suppose in the case of diarrhea, you have consumed contaminated water and within few hours, 6 hours, maximum 24 hours, you will develop loose motion, vomiting, pain abdomen, etc. So, for short duration of illness, screening test is not applied. There is no scope of applying screening test. So, screening test is applied where there is a sufficient period between preclinical or subclinical stage up to the stage of development of signs and symptoms. If you take the example of diabetes, if you take the example of hypertension, many hypertensive patients are normal, no abnormality, but after 10 years, patient will develop some complaint. Similarly, in case of diabetes, initially patient has high blood sugar, but there is no problem. No retinal problem, no cardiac problem, no neurological problem. Patient is moving, working, only mild tiredness. But patient will not come to you for just mild weakness. So, in this way, patient is working for 7 years, 8 years, but after 10 years or 15 years, patient will come to you with some complaint or with some complications. So, there is a prolonged period. Clear? For these are the cases where screening test can be done. Next is the screening test must be acceptable to the society. If you think about detection of cervical cancer, detection of cervical cancer by means of pap smear. In India, many rural women will not participate because the test is embarrassing. Test is embarrassing, particularly to a male gynecologist. It is not a Western country that almost all women will come for doing pap smear. So, it is the acceptability of the community you have to think. So, this test is not so much acceptable in the society. So, it is a drawback for doing pap smear among the rural women. Clear? So, one is, it must be a public health problem. Next one is, there must be a sufficient knowledge regarding natural history of the disease. There must be a sufficient period between onset of preclinical stage and onset of signs and symptoms. Clear? Next is, there must be a screening test which gives good result in terms of sensitivity and specificity. Sensitivity, specificity পরে আসছি. The test must be good enough to give good result in terms of sensitivity and specificity. There must be a confirmatory test. Confirmatory test must be there. Confirmatory test must be there. Suppose, in case of syphilis, we do for syphilis, we do viral test, but confirmatory test is done by means of ওদের মাইক্রোলজি পড়ানো হচ্ছে তো হ্যাঁ ও হয়ে গেছে তাহলে তো আমার থেকে ভালো জানো হ্যাঁ ট্রিপোনেমা প্যালিডাম absorption test, it is a confirmatory test. So, the disease for which we are doing screening test, there must be confirmatory test. Until and unless we do confirmation, we will not be able to treat the patient. Next is, treatment facilities must be there. আমার একটা ডিজিজ যার ট্রিটমেন্ট ফ্যাসিলিটি নেই, ট্রিটমেন্ট ফ্যাসিলিটি আমার জানা নেই, তো সেই ডিজিজের আমার স্ক্রিনিং টেস্ট করে তো লাভ নেই। সো ট্রিটমেন্ট ফ্যাসিলিটিস মাস্ট বি দেয়ার। নেক্সট ইজ, by means of screening, we will be able to detect cases earlier so as to reduce mortality and morbidity. If we can detect undiagnosed cases in the community and if we can give treatment at an early stage, we may prevent morbidity and also we can prevent mortality. So, there must be reduction of mortality and morbidity by applying screening test. Clear? Next is, if we consider outcome, the outcome, what is outcome? Outcome means reduction in mortality or saving the lives of the diseased persons. So, this outcome must be beneficial in comparison to cost which we have incurred for doing this screening test. Suppose আমি 1000 লোককে স্ক্রিনিং করলাম, স্ক্রিনিং করতে আমার ম্যান পাওয়ার লাগবে, মানি লাগবে, ট্রান্সপোর্ট লাগবে, ইকুইপমেন্ট লাগবে, রিয়েজেন্ট লাগবে, এই যে কস্ট, এই কস্ট যেটা হলো, আর আমি স্ক্রিনিং করে যত আনডায়াগনোজড ডিজিজ ডিটেক্ট করলাম তাদের কমপ্লিকেশন বা মর্টালিটি যেটা আমি প্রিভেন্ট করলাম তার মনিটারি টার্ম আমি যদি ক্যালকুলেট করি, আর এইখানে যে আমি মনিটারি টার্ম ইউজ করেছি সেটা কোনটা বেনিফিশিয়াল হবে? স্ক্রিনিংয়ের কস্টটা কম হবে। যদি আমি স্ক্রিনিং না করতাম সে আমার 100টা আনডায়াগনোজড পেশেন্ট থাকতো, তারা আর্লি এজে মারা যেত। নর্মাল লাইফ এক্সপেক্টেন্সি কত? রাফলি 68 ইয়ার্স। 68 ইয়ার্স, তাহলে একটা লোক যদি 50 বছরে মারা যায় তাহলে সে আরো ওয়ার্কিং কন্ডিশন আরো 10 বছর কাটাতে পারতো। তাহলে 10 ইয়ার্সে তার কত ম্যান আওয়ার্স লস, তার এডুকেশন স্ট্যাটাস, এটা হিসেব করে দেখা যাচ্ছে যে ওইখানে যে কস্টটা হতো ওই লোকটা যদি আগে না মারা যেত তাহলে সেই কষ্ট দেখা যাচ্ছে অনেক বেশি। বোঝাতে পারলাম? হ্যাঁ? So the cost incurred for the screening must be less in comparison to outcome of this screening procedure.
এটা দেখা যাচ্ছে? দেখা যাচ্ছে? So if we take the example of diabetes mellitus, we have done PBBS, postprandial blood sugar test. Based on that, we have diagnosed few cases having disease and few cases not diseased. So how confirmation is done? Confirmation test is done by means of glucose tolerance test. So initially screening test was done. Based on that, few patients were positive and few patients were negative. And finally we have done glucose tolerance test among the positive cases. Clear? And based on that, we have classified into two groups, one having disease and another having not diseased. So what is sensitivity? Sensitivity means sensitivity is, it is the ability of a test, it is the ability of a test to detect those cases which have the disease. Ability of a test to detect those cases which have the disease. So how it is calculated? It is calculated by means of A by A plus C into 100. It is expressed in 100. It is expressed in 100. A by A plus C into 100. It is the sensitivity. It is the ability of a test to detect those cases which have the disease. Next is specificity. What is specificity? It is the ability of a test to identify those cases which have no disease. It is the ability of a test to identify those cases which don't have the disease, and it is expressed in 100. তাহলে sensitivity and specificity, these are the important terminology for accuracy of a test. Now, what is the predictive value? Predictive value. Predictive value of a positive test result, A by A plus B into 100, A by A plus B into 100. Predictive value for positive result, and predictive value for negative result, predictive value for negative result, D by C plus D into 100. D by C plus D into 100. So one is sensitivity, another is predictive value. Predictive value means it is the diagnostic power of a screening test. Predictive value is the diagnostic power of a screening test, and it also depends on prevalence of the disease. If the prevalence of the disease is high, predictive value will be more. Clear? Now, you take some example, A, B, C, D in figure form. Right now, capillary blood glucose reading was taken in a village where both diabetics and non-diabetics have been categorized with HbA1c diagnostic test. HbA1c diagnostic test, full stop. The following findings were elicited and presented as below. Capillary blood glucose, in case of screening test, it is the capillary blood glucose. In case of screening test, it is the capillary blood glucose. And HbA1c test for diagnosis, HbA1c glycated hemoglobin. কতর বেশি হলে ডায়াবেটিস বলবো? গ্লাইকেটেড হিমোগ্লোবিন 6.5 and above. Clear? তাহলে 6.5 and above হলে আমি ডায়াবেটিক বলবো। তাহলে it is the confirmatory test for detection of diabetes. So based on HbA1c, now let us see the figure. Positive 350, positive 350, and negative 2150, 2150. What is the total? Total 2500. এই দুটো যোগ করলে 2500. Next is negative. Negative, true negative কত? 7600. True negative 7600. And false negative 150. Total কত আসছে? 7750. 7750. এটা টোটাল 10250. এটা টোটাল 500, 500. Total 9750. 9750. Calculate the sensitivity and positive predictive value of the screening test. Calculate sensitivity, specificity and positive predictive value of the screening test. করা যাবে? সেন্সিটিভিটি কি বলেছি? A by A plus C into 100, A by A plus C into 100, ফিগারগুলো বসিয়ে দাও। স্পেসিফিসিটি কি হবে? D by B plus D into 100, আর পজিটিভ প্রেডিক্টিভ ভ্যালু A by A plus B into 100, এই যে পজিটিভ প্রেডিক্টিভ ভ্যালু, এটা হচ্ছে নেগেটিভ প্রেডিক্টিভ ভ্যালু আর এটা হচ্ছে পজিটিভ প্রেডিক্টিভ ভ্যালু। হ্যাঁ, এটা পজিটিভ প্রেডিক্টিভ ভ্যালু আর নেগেটিভ প্রেডিক্টিভ ভ্যালু D by C plus D into 100. Specificity D by B plus D into 100, sensitivity A by A plus C into 100. ঠিক আছে? This type of question will be given in your exam, and if you can calculate correctly, you will get 5 out of 5, you will get 5. But if you cannot calculate, you will get 0. কি খুব শক্ত মনে হচ্ছে? হ্যাঁ, the sensitivity and specificity, these are the two important terminology in terms of validity or accuracy. But the physicians or the treating doctors, they are more concerned about false positive and false negative. They are more concerned about false positive and false negative, because this test was done and it was found that 30% were falsely positive or 30% were falsely negative. So he will not be able to treat the patient based on this screening test. So that's why they will do further investigation by means of confirmatory test. So in case of syphilis, initially we do VDRL or RPR. Next, among those positive VDRL cases, they are further tested by means of Treponema pallidum absorption test. This is confirmatory. That means here specificity is almost 99%. Specificity is almost 99%. So what should be the cutoff level for doing screening test? It depends on one important factor is whether disease is highly fatal or highly lethal. Suppose if we consider the breast cancer or cervical cancer, because we will diagnose the cases at an early stage. So our specificity will be high. But in case of diabetes, our blood sugar level will be set to such a level that there will be not too much of cases. If we suppose if we say the cutoff level 120, more number of patient will be labeled as diabetes, as having high blood sugar above 20, but these more number of cases will claim for treatment. But in case of diabetes, if we do not treat the cases who has borderline blood sugar level, there will be no alteration in the outcome. Patient will be advised to do screening test further after 6 months or after 1 year. It will give no harm. But in case of HIV or in case of breast cancer or in case of cervical cancer, if we miss the cases at an early stage, then we will not get the opportunity to treat the case earlier. So we will set the cutoff level in such a way that more number of cases will be detected at an early stage, so that we can do final test, and ultimately we will be able to detect the cases earlier and we will be able to give the treatment accordingly.